Okay, good evening, everyone. I noticed that already a few people are starting to join us. We will go ahead in a few minutes and allow everyone to join the meeting. In the meanwhile, for those who already joined, a very warm welcome on behalf of the European Resuscitation Council. You can see in the background the meeting rules appearing, so questions will be able to ask through the Q&A, and we will try, given the restrained time we have, we will try to answer major questions during the discussion. Other questions can always be asked afterwards through our email address that also appears on your screen, webinar@erc.edu, and we will put all those answers on the FAQ of our COVID webpage. So don't worry if your question is not addressed today, we will make sure to do that in the very near future as well. Still a lot of people coming in. I see 326 participants already in our meeting. Just wait a few more minutes. And I see that we already have a first question. Can we have a certificate about the meeting? Well, I will check that for you and answer that by the end of the meeting. Thank you, Lama, for your question. And Bjorn, sure, we will record the meeting, and we will put a copy of the meeting, of the webinar on our website as well. Okay, it's 6 o'clock, so I think we should start in time in order to use the time we have. Once again, a very warm welcome to everyone on behalf of European Resuscitation Council. I'm glad to host our first webinar on basic courses. I'm happy to host a number of experts in the field who will talk us about basic life support in lay people, healthcare providers, and children. Welcome Federico Semeraro. Welcome Theresa Olasveengen. Welcome Patrick Van de Voorde. Welcome Tino Greif, who is our Director Training and Education, and will join us in the discussion afterwards. Before we start, so every expert will give a short presentation summarizing the highlights of the COVID guideline changes for each chapter. And afterwards we will engage in a panel discussion on how to safely resume those courses. But before we start with the effective presentations, I would like to welcome our chairman, Jerry Nolan, as well, and hand over to him to give us a short welcome and introduction. Good evening, Jerry.
Good evening, Nicolas, and good evening, everybody on the seminar. I'm going to try and get my slides shared with you if I can. So, welcome to this first ERC seminar, and I suspect this is the format that we will be adopting for some time to come for some of our educational sessions. My thanks to everybody that's put a huge amount of work into putting this together. We're going to be talking about how we can go about safely resuming ERC courses. And this is the first of two webinars this evening. This is going to be on basic life support, and then we have one later on advanced life support. I was going to say just a few very brief words by way of introduction. I suspect that most of you listening to this will be well aware of the significant crisis that has affected us. We've been involved, I guess, with this SARS-CoV coronavirus 2 pandemic now. Well, really starting in China, there's a little bit of debate about when it started in China, but certainly right at the end of December. And I think it came across into Europe. In fact, the first case in Lombardy in Italy around about the 20th of February. And in fact, that's significant because Federico Semeraro, who you'll hear from in a moment, works and lives in that area of Italy. So he has a lot of experience with this disease. It's affected all of us in a massive way, of course, not just to do with resuscitation, but in all aspects of our lives. And I think there are a number of facets to this, this really quite horrible disease. Firstly, of course, there is a significant risk to patients, and we know it's very, very easily transmitted, and for some patients it has devastating consequences. Secondly, of course, we're aware of risk to healthcare workers, and the picture you see on the right of that slide there is, of course, Li Wangling, who was the doctor in China who alerted everybody to the threat of this disease and sadly died from it himself. So there is a risk there, but we have to balance all these risks, and I think that's a very important point, which I'll come to in a moment. This is a screenshot that I took from a site which I suspect many of you are familiar with. It's a site operated by Johns Hopkins Hospital, and you can see about 7.5 million confirmed cases worldwide to date. And sadly, if you go and look at it's probably a little bit too small for you to see, but as somebody that lives and works in the United Kingdom, I sadly have to report that we're sitting number 2 in the world at the moment for the highest number of deaths. So it's a significant disease. It affected us, as far as cardiac arrest is concerned, in a number of ways. We're all aware soon after the onset of this pandemic that we had a complete lockdown and diversion really of us as clinicians, perhaps away from being able to train in CPR to obviously very important life-saving clinical duties. So there was a couple of reasons, or fundamental reasons, why training has really been on hold pretty well since then, although beginning to reopen now. And that is because of those doing the training having to do clinical duties, of course, but also there was a perceived risk of groups gathering together and possibly transmitting the coronavirus between them whilst being trained. So there was two elements of that. We now see from a number of published data, I'm not going to go into all the details of those, a number of things happening. The incidence of cardiac arrest, certainly for out of hospital, is clearly increasing. We've got reports now from Italy and from France, and there's others coming in. And sadly, and perhaps not surprisingly, we are seeing a significant reduction in the incidence of bystander CPR, probably because of the concern about coronavirus, and consequently, of course, an increase in mortality rate. So as many of our countries across Europe now are beginning to emerge from lockdown, there is a time really to return to what will become the new normal. We are never going to go back to exactly where we were before, at least that's my own personal view. But I think it's time that we start to consider the relative risks and balancing those risks and benefits, because we must recognize there is a small risk of transmission of this disease to rescuers and to healthcare providers, but there is also substantial risk to lay people out of hospital and patients in hospital if there was a delay in CPR. And we clearly recognize that both the public and healthcare providers both need resuscitation training if their skills are going to be maintained. It is our belief, and you'll hear about how we might be able to do that with the next presentations, but it's our belief, or the ERC's belief, that training can be provided with minimal risk to participants, and we'll give you tips and ideas on how to do that. And so I think in terms of the practicalities of how we return to the new normal, it's a pleasure to hand over to our next speaker, and I'll hopefully stop sharing my screen.
Thank you very much, Jerry, for your introduction. First of all, let me go back to our audience because we also would like to involve you, and we prepared 3 polls to get a little bit into knowing you. And the first poll will appear on your screen right now, and is to know who is attending our session, so that we have an idea who we are addressing today, and which course type you are merely engaged in. So I will give you a couple of minutes or a couple of seconds at least, to answer this poll. And I'm happy to notice already that we have a lot of instructors present this evening. Also a number of course directors, 30% of course directors, some industry representatives. %70 of you already answered. I will just give you a little bit more time. Before ending the poll. Okay, and we will close our poll right now. We have almost 80% of answers, and not surprisingly, most of you are engaged in basic life support. Of course, that is the theme of our webinar, with a lot of instructors and course directors and organizer as well represented tonight. Thank you for your answers. We will move on to our first speaker, which is Federico Semeraro from Italy. And Federico will talk us about the main changes due to COVID in basic life support for lay people. Welcome, Federico.
Thank you, nice presentation, Nicolas. It's a real pleasure to be with all of you virtually. We are a lot of people around all over the Europe. I'm very happy to share with you some sad experience from Italy. And I'm happy to share also some brainstorming around basic life support for a rescue. So, okay, I am a consultant in anesthesia intensive care in Bologna. I worked in the last 3 months in intensive care and in EMS field. I'm also the European Resuscitation Council BLS SEC co-chair. So everybody know that everything changed in the last 3 months. So we need to rebuild and rethink the way to treat the cardiac arrest, and we need to rethink and rebuild how to teach the new way to teach BLS. So first of all, in terms of recognition, obviously we need to don't open the highway or place your face next to the victim on the nose because it's risky. So we can check responsive and breathing in a new way, in the COVID-19 way. I'll show you 2 local implementation suggested by ERC. For example, in UK, they keep shake and shoulder classical old-fashioned way. In Italy, they change and locally suggest to shake and shoulder in the upper part of the body. So the important is obviously to reduce the risk to during the contact with the victim during recognition. So when you check if it's unresponsive and not breathing, obviously you have to call EMS. And if you are aware that is a COVID-19 patient infected or not, you have to in some way inform the dispatch center about the status of the patient. Regarding chest compression, in several nations, there is an obligation to use a surgical mask, just in case you have to use some clothes to put on mouth or nose before start chest compression, because chest compression, you know, is an aerosol generator of, it can increase in some way the risk. So the instruction for use for chest compression, it's always this not change. Chest compression rate between 100 and 120, a chest compression that between 5 and 6. Obviously, if we arrive an AD, use an AD and switch and follow the instruction. From the perspective of dispatch center regarding lay rescue, I can say for pre-arrival instruction, nothing changed because frequently we suggest chest compression only. Obviously, we need, as a dispatch center, suggest to use a surgical mask or in some way use some to cover the mouth and the nose. And obviously suggest to find in the around the scene. Regarding first responder, obviously this is a decision locally based, because in some system first responder is integrated in EMS system. So if it's integrated in EMS system, we suggest to be sure that they are trained to use airborne precaution PPE. Just in case, for example, in Italy, we are a first responder system based on voluntary base. We are not sure that they are totally safe. So it's voluntary based. At the end of the story, obviously, everybody needs to wash their hand and contact the local authorities to check the status of COVID-19 patient and maybe do some exam for risk of infection. Regarding the pathway, very, very quickly, it's easy for us to teach knowledge through COSI or through e-learning system. I think this is a real positive collateral effect of COVID-19. We can spend a lot of resource and idea on new way to teach knowledge through webinar and e-learning and COSI. It's challenging for skill because, you know, BLS is, there are a lot of skill and we have to redesign or rethink how we can teach chest compression. We need to understand the balance between the risk to teach ventilation, but it's could be very challenging for lay rescue. So we'll see what we can build as a new story for teach to lay people. Regarding PPE, this is a good chance to also teach the candidates to use the PPE appropriately. Regarding, obviously, in the middle of pandemic, it's absolutely too much risky to teach and use mouth-to-mouth ventilation in clinical setting and in teaching setting. So for other information, as usual, on ERC COVID-19 guideline on the website, and keep the distance with masks. May the force be with you. Thank you.
Thank you, Federico, for this clear resume of the major changes. I see that in the meanwhile, a number of questions are already coming in. As said in the beginning, we will try to answer the most important ones at the end of during the panel discussion. So feel free to ask them through the Q&A or email them, and we'll make sure that every question is addressed afterwards on the Q&A of our, on the FAQ, sorry, of our web page. Our next speaker is Theresa Olasveengen, who will talk a little bit about basic life support in healthcare providers. Hi, Theresa.
Hi, thank you. Okay, so it's my turn to share the screen. Okay, so what I was hoping to do was say something about why we made separate guidelines for healthcare workers, and to give you a bit of insight into the discussions that we had in making these guidelines. And I think it's important to be humble and honest about the sort of the lack of knowledge and the lack of evidence that went into this, and yeah, just be transparent on the sort of many difficult discussions that we had. So why do we have separate guidelines for healthcare workers? Well, I think number one, I think there's a very different risk limit, for healthcare workers. This is our job, and we're certainly at a higher risk of getting infected by COVID as we're treating COVID patients. And I think not only sort of the risk to the provider, but the seeing the provider get sick, then there's no one in quarantine, a large amount of staff, as I'm sure many of you have experienced. Then there's you run into problems having enough staff to take care of other sick people. And then we are in a unique situation to infect other vulnerable patients. And I think this was important, for us in the discussions that we had in developing these guidelines. And also ventilation. Ventilation, I think, remains to be somewhat controversial in BLS. How important is it? How important is it early? And there's definitely, I think, a different expectation for healthcare workers in terms of being able to manage an airway. So just again, I think the most important thing that, the most important discussions we had was, how do we ensure healthcare workers' safety? And, it seems like an obvious statement to say that, any team responding to a cardiac arrest should have access to and training in airborne precaution PPE. But I think as many of us experienced, that wasn't all that obvious. And I think it was important for us to be clear that this was a priority, and that it was important for healthcare workers to expect that kind of protection. And then we also wanted to be a little bit, wanted to differentiate risk somewhat, because we had a lot of discussion about defibrillation. Now there are theoretical, we're not 100% sure how contagious doing CPR is. And we had discussions, what if you have a patient that's on the general ward, it's not an ICU patient, there are no aerosol generating procedures going on, and you have an AED right outside. So the attending staff would not be donning a full droplet, or would not be donning a full sort of aerosol generating PPE when attending the patient. Do we really want to wait to put on all of that gear and get everything in order just to give a defibrillation? And the sort of the pro and con was that the risk of, defibrillation with self-adhesive pads is probably so low that it seems like a much greater risk to the patient. So again, the sort of course, there are a lot of ways of teaching CPR. There are a lot of sort of variants in how it's actually practiced. But again, it is the whole ventilation that I think scares us in terms of generating aerosols and it becoming very contagious. So I thought, it seems like a common sense, thing to recommend, to say, let's just do, if you're going to do 30 to 2, then take proper pauses, do 30 compressions, pause, give the 2 ventilations, so that you're in control. And if you're not skilled, if you're not very comfortable doing ventilations, then it's probably best not to do it. And I think a perfectly reasonable alternative is to place an oxygen mask over the nose and mouth, and I think that might offer some protection of contagion and perhaps some oxygenation. And then, of course, this picture is obviously not donning the proper PPE, but again, focusing on, if you're going to give ventilations, let's do it safely, and let's, make sure that our healthcare workers are safe. So recommending a 2 hands approach, where you're actually needing 2 people to do sort of high quality, safe ventilation during CPR in a suspected COVID case. So one person just making sure that you have a very tight seal on your mask, the other person handling the bag. And I think that's what I was going to say, just very briefly, and hopefully we'll have some more discussions and questions on both, you know, what considerations went into this, but also, you know, how do we now move forward with training and CPR. Thank you.
Thank you very much, Theresa, for your clear summary. We will move on. Still a lot of questions coming in. Just want to repeat once more that we'll not be able to address everyone in detail tonight, but you'll find the answers afterwards on the FAQ of our web page. Our next speaker, Patrick Van de Voorde, Belgium, who will talk about basic life support in children. Patrick, welcome. Good evening.
Hi, hey. Hello, good evening. I think a lot of what my colleague said, the previous speaker said, is also true in pediatrics, and I'll share my screen in the meantime. And especially we have even less evidence, so we're always a bit looking also at what comes out from adult literature, even though the reality in pediatrics is different. In children, there's a low incidence. There's more and more papers out there showing the low incidence, and also especially that children are low spreaders. So children can become severely ill from COVID, but the majority will have another disease. And if you then look at what Jerry said as well, the balancing of risks, there's definitely still a small risk to the provider, but there's an even greater risk to the child if we do not provide CPR. And finding that optimal balance is what we need to do now and in the future, and this also involves how to restart our courses. Now, what is even more specific is that, of course, in the reality of a child going into arrest, it's quite often the caretaker that will be the person who is bystanding, who is involved in the resuscitation, and he or she might be more willing and able, and that's why we use that term specifically. If you already had previous contact, if there's a presumed low risk, if you feel you are already involved with the victim, then you probably will be willing and able to provide full CPR. And that will very much influence our flow chart of how we propose to do it, focusing actually on little has changed. There's obviously another context, but little has changed. We still would define as cardiac arrest unconscious, not breathing normal. But similar to our adult colleagues, would not go for look, listen, feel, recognizing cardiac arrest. We still would have a second rescuer calling immediately, but for the single rescuer, and this is a difference, we would say call before starting compressions, call earlier so you get more and proper protected support earlier on. Those willing and able, and there you have the willing and able, should also provide the ventilation part, opening the airway, providing rescue breaths, because it will make a difference to the outcome of the child. And if for some reason, because it's a voluntary thing, you would not want to do this, then at least provide compressions. And if so, like in the adults, if you provide compressions, cover yourself, your face and mouth, and cover the face and mask out of the child. And actually, for the rest, there's no difference in terms of what we advise as a guideline, being based on low evidence. How do we then start retraining? Because there again, we know that basic life support saves lives, when you include ventilations especially. You cannot only train online, you need this instructor-led training. But of course, there's an unknown risk of COVID when you resuscitate a child, but also when you interact with other people. This you know the word social distancing, and we should keep this in our courses. But not starting training will impact outcome, and that's for sure. So, and I think this will come back in the discussion later on. There's probably certain groups will need retraining earlier than other groups. Like I said, the majority of what we teach should be very similar. So that means for pediatrics that teaching ventilations, even mouth to mouth or mouth to mouth nose, should be part of that training. We've discussed a lot, and there's not very clear-cut evidence, but we discussed a lot how to do it. And actually, every participant should have his own airway for the moment. There's insufficient safety to start using one mannequin with different participants. Now, I know that a lot of companies will be happy to help out, getting more lungs, getting more mannequins out there at better conditions, so people can do this restarting. Still a long way to go, but I think we'll get there. Thank you very much.
Thank you, Patrick, for your presentation. And as you correctly stated, it's all about balancing, and we see there is still a lot we don't know. For sure, there are already a number of answers, and we will focus on the restart of the courses this evening. And before going to the panel discussion on how to safely restart courses, I'd like to know from our audience if at this moment they feel they have enough information to safely restart ERC courses in their country. And we can put up that poll in order to allow everyone to answer that. And second question is whether they already restarted courses in their respective country, knowing that the situation is still different from country to country. And we'll ask you the same question after the panel discussion, and hopefully we'd notice some changes and have been able to provide you some useful insights with regard to restart and safely teaching ERC courses. So I'll give you a couple of seconds more to answer the poll. 60% already did. And I'm happy to see that our COVID guidelines are already for almost 60% of you feel that they have enough information to restart courses. 23% unfortunately already restarted courses in their countries. So might be useful to have an in-depth discussion on why or what the barriers are to restart courses, and how we can turn those no into yeses and help everyone in restart the courses in a safe way. We will end the poll right now, and we will engage in our panel discussion. And my first question to our panelists is, well, why should we restart courses despite the risk of COVID-19 infection, both for faculty and for participants? So why should we restart right now? And already Patrick gave a little of the answer, so maybe Patrick, you can comment on that.
Am I muted or unmuted? That is the question.
Unmuted.
Okay, there you go. Yeah, I think it's equally for adults, but I'll only talk about the children. There's, on the one hand, I think we need to. There's a lot of people working with children that need training. Some of them could probably still work with what they've been trained in the past, but we know that skills and knowledge declines. And also we have now a specific situation, and I think training can also help to counteract the fear and make people confident again about resuscitation. And I think that's very important, because if we believe that we can change outcome by doing resuscitation and by doing high quality basic life support, then not doing it is also impacting outcome in the other way.
Okay, so that's clear. Someone how can we actively minimize the risk for faculty and candidates when resuming our trainings? Who would like to comment on that? Federico.
I also add some comment to the previous question. I think we absolutely need to restart, because the balance between the risk of infection and the risk of a lot of death on the scene based on cardiac arrest, we absolutely need to restart. First of all, for kids, because they need ventilation, but in the balance of the risk, absolutely we need to restart to train, and we need to restart to resuscitate all the patients without, we need to give some good recommendation to reduce the fear around healthcare professional and citizen. Regarding the safety for courses, I can say easily, we spend a lot of time together with our colleagues with surgical mask and gloves. So if you want to organize a course, we need to respect some easy rules: a surgical mask, gloves, clean the mannequin, wash your hands. So it's not so difficult to transpose your clinical approach to the problem to the training site. I think it's not so complicated.
Okay, anyone else? Tino, I see that you want to comment on that as well.
I only want to bring in, why should we start courses? That's quite a nice study from the AHA, which I could show you only one paragraph if I share my screen, if I get this done. Yeah, here. They made a study, they looked at infection rate, and they had about 15 deaths in 100,000 patients, and they calculated that maybe one bystander will be infected and one will die in 10,000 bystander CPI events. In their population, this is in the US, and they had quite a high infection rate. On the other hand, we know that CPR saves more than 300 lives in 10,000 patients. So if we don't do CPR, these 300 patients will not have the chance to survive. And obviously, this is a hard number. One rescuer might die in 10,000, but this is a huge difference. And if you don't start again, teaching people doing CPR, and especially basic life support, because these are the first people who are really helping and giving the people a chance to survive. This was only a short input, and with this I would like to step back from this. There's also evidence that the downside is some people might get infected if they really are helping in BLS in cases, but on the other hand, a lot of people will die, and we have more and more data how in the emergency rooms, cardiac arrests are going down, stroke is going down, people are not coming to the hospital, and we still don't know what happened over the last 3 months with all these people. Appendicitis was surgery reported, less appendicitis. This is strange.
Okay, thank you, Tino. I see a lot of questions coming from our audience with regard to PPE and PPE during not only resuscitation in real life, but also during teaching. Anyone who can clarify on that? How do we use the PPE? Do we use them during training? What about protective equipment, back valve mask? Do we have to use it with or without a HEPA filter, is asked by one of our participants. So, Patrick.
Well, one thing is for sure is that mannequins are not breathing. Of course, pediatric mannequins have relatively small lungs, and there's no backward valve. So if you would do mouth to mouth, then eventually droplets will start to mix, and that would be a risk. So we would say for mouth to mouth, everybody would need his own airway and his own lung, and does his own mannequin in a way. Otherwise you would have to change. But for back mask, I do not see any added value of having a filter in a testing setting. It's another thing, of course, when you ventilate the person in reality, and I see Tino also waving. And then, of course, one thing I wanted to say for the discussion I was already past us is that we want to minimize risk, definitely, but any sort of interaction also previously, historically, this was never zero risk in what we do, not as a healthcare provider, not as a bystander, not as a person living. So I think trying to now get a zero risk is equally strange if we did not have it at any moment in time.
Okay, then anyone would like to add something about that, Tino?
From the educational point of view, I would strongly recommend to use these filters, because that's the saying, you train as you fight. And if you want that people are using these filters in between the mask and the bag, then train it. And this is the same for the PPE. The mannequin will not infect you, but if you want that people are using gloves, eye protection, mask, then they have to train it. That's the point why it should be used in training. It will not have this effect because the mannequin will not infect you. Other people, but with other people you can have distance, and mask and eye protection is enough. The major issue, train as you want that they are practicing afterwards.
Okay, Federico, you wanted to comment? Or Theresa, sorry.
Please, Theresa.
I just wanted to, I mean, it perhaps is obvious, but I think we're at so different stages in various parts of Europe that obviously, I mean, it's reasonable to follow the local guidance wherever you are. We have several regions in Norway that hasn't had a single COVID case. And obviously for them to suddenly start and do things very differently, there's no reason. They have, you know, no known infection in their area. So, I mean, obviously it's just to be clear, we are sort of talking about the setting where there is a real concern. And we're actually getting to the place, many places now, that's not really the case anymore.
Okay, I have a question from Monique, who remarks that, well, back valve mask is not an easy technique, especially for basic life support. What would you advise on that? Everyone has to learn to use a back valve mask, or what is the alternative?
So I don't know who wants to take that one. It's a difficult question.
The alternative is chest compression only. If somebody is not willing or can't do proper ventilation, they should do chest compression only. Those people who have a mask and are able to do it should try it. For me, it's a very simple decision, because basic life support is the first aid, and we hope that the next team with more skills arrive soon. The major point now is really to convince people, lay persons, to start CPR, to start chest compression only.
Okay, Federico.
Yes, the problem, as in the pre-COVID area, infection could be an excuse to not start CPR. So we need absolutely to give a very real, pragmatic suggestion. So if you don't want to use ventilation, so okay, chest compression only, it's better than nothing. But I can say we discussed a lot around this. If you have a mask, or you are able to use a back mask ventilation, in special cases, think about droning or asphyxial cardiac arrest, or think to pediatric cases. If you are able to use, you have to use back mask ventilation in terms of risk, because if you don't use that for pediatric cases, maybe that kids, that it's a real disaster. Regarding the training, many of you maybe try how is could be not easy to start chest compression with FFP2 or FFP3. So I agree with Tino. Maybe we need to learn and teach with appropriate PPE. During chest compression, it's very hard to use PPE. It's very hard to breathe with FFP2 or FFP3. So we need to teach and train.
Okay. In addition to that, Federico, I see some questions popping up for lay people. What PPE would you recommend for training lay people in basic life support? Gloves, surgical mud? Do they need a shield protection as well?
I think during a traditional course, a surgical mask and gloves, it's enough with glasses. But again, if you want to reproduce high fidelity basic life support, you have to use FFP2 or FFP3 if you use in real life. So if you are a lay people, I imagine that you always use a surgical mask in real life. So in a simulation, you need to use a surgical mask.
Okay, thank you for that. Tino.
Nicolas, this depends. If you are in a training situation where you teach lay people, then gloves, mask, and maybe eye protection is enough. If you have to train your hospital staff, and EMS staff, then PPE, full PPE is included. So this depends. What are you teaching?
Mm-hmm.
Okay, thank you. So that already.
I think, Nicolas, it's not only about PPE, of course, it's also, for instance, coming back to the back mask, is that, of course, if you are not used to using it, then, like Federico said, it's probably not something that you can use, that you should compressions only, but there are subgroups, not only children, but I think also, like you said, drowning, but also a lot of people in hospital are not primary cardiac arrests, and a lot of them are oxygenation, ventilation, and then I think we should aim to teach back mask ventilation with two-person technique to more people who previously would have used a face mask or mouth-to-mouth. I think we need to switch them to more back mask training.
Okay, a number of people are also raising the concern that well, training with PPE or more frequently changing or need to clean the mannequins can be time consuming, can enhance the costs of a training. Anyone who wants to comment on that topic, because I think it's an important remark.
Yeah, it will enhance costs. You might have less people in a course because of the distance you should have, and this is then to calculate on the local organizer. But at the moment, this should not be an excuse not to start the courses. You have to think maybe less people in a room. You need a little bit more time, all the cleaning procedures, but at the end, it's BLS teaching, and we have to start and to do it.
Yeah.
And I think Nicolas, like I said, also business partners, companies are well aware of that problem and are trying to facilitate. And I think this is the time to definitely discuss with them about having packs so you can have more mannequins, more lungs and airways equipment to facilitate your training. And I think this is a moment to discuss in partnership how to get there. And they will definitely support, because we have something in common, trying to get CPR going.
Okay. Well, in addition to that, some questions are also raised about ventilation in drowning, and a number of lifeguards are attending our webinar. What about ventilating in drowning or near drowning patients?
We still don't know exactly what is going on with the virus in water. But what I think is, these people are first responders with a duty to act, and maybe we have to make a step forward and start to teach also these people, these organizations in back mask ventilations, because they could have it there. It's not so hard to bring it in to make it a little bit safer. Otherwise, if you really have rescue a patient from water and you still think you can resuscitate them, ventilating the lung it's an issue of highest priority. The decision is then for you, are you going to do, if you don't have anything, mouth to mouth, or you say, no, I don't want to do this for the infection risk and start chest compression only till somebody comes in with a mask and a bag. But from the training issue, I think this is something for a very specific rescuer population, which can be changed.
Mm. Yeah, I fully agree. Now, I think, and I was also going to say the same sentence in another discussion already, is whatever we advise, of course, every local country and even regional will have his own guidelines and his own laws and regulations. And whatever we say, it's the laws and regulations of your country or even your hospital that might guide what you can do and must do. The only thing we then can do, and ERC can help, but you also have to do it locally, I think, is have advocacy to induce change. For instance, by saying this is a population we think that should be able to train in back mask and use back mask ventilation, for instance.
Okay, we are moving forward in time as well, and I will just ask you one final question that appears a number of times, and it regards foreign body airway obstruction and recovery position is a question that comes by a number of times. Anyone who want to comment on this item?
What was the question?
Well, how do we handle foreign body airway obstruction during COVID, and do we still practice recovery position?
Well, I think recovery position would be sort of less controversial, and I think at the sort of extremes in both ends, you know, if you're a healthcare worker, then you know, responding to medical emergencies, you should have access to and have proper training in PPE or personal protection equipment. But and as such, I think you would pretty much do what you normally would do. But I'm sure the question's more perhaps of the lay rescuer, or and you know, I think for all practical purposes, I think a lay rescuer would probably do what they normally do to try and sort of relieve the obstruction.
Okay. Yeah, I agree with Theresa. The only thing is to remove surgical mask before you, because maybe it's not so, you know, but nothing changed in terms of choking. Absolutely nothing changed. Only to be aware and wash your hand at the end of the resuscitation.
Try to wear a mask yourself. And what we said in the beginning, because of course this is also something that pediatrically is absolutely an issue. As long as there's a efficient cough, you stay at a distance and you just support without any maneuvers like before, with proper distance and with a mask on as a rescuer. But otherwise, I think it's the added value of acting is as such that you cannot stand aside. And for safety position, I think, of course, this at the training level, this is also interaction between people and at a close distance. So for now, it's not on the high priority list to train that. You can also do it by watching the video on the e-learning beforehand, and it diminishes contact between people. So, and it frees up a bit of time to explain about PPE and all these sort of things in many courses. So we sort of skipped it for the moment.
Okay, thank you very much, everyone. Just want to repeat for our audience that we have a free e-learning available on the guidelines you have to use during COVID-19 and the post-pandemic period. They are freely available in an e-learning on our COSI platform. And with regard to the guidelines to safely restart ERC courses, a guidance has been drafted and is also to be found on our ERC COVID landing page online. In the meanwhile, I would like to ask you or to invite you to re-answer our two poll questions, and I will relaunch that right now, and to see if we've made any difference and if the mist has a little bit cleared up for some of you. As I already said, not every question could have been answered in detail. We will make sure to do that afterwards on our FAQ page. Feel free to send us your questions by email at webinar@erc.edu. If you have more questions, leave us your name and email address, and we'll get back to you with the appropriate answer. Well, we had 60% of people who thought they had enough information by the start of our discussion, and that moved up to 90% after our discussion. So thank you to all our experts for your achievement. And we had like 40% of the people stating that they already restarted courses, and 80% or 84% now says that they are likely to restart courses in the coming period in their country. We will close the poll here. I would like to give a special thank to all the participants who made time to follow our webinar tonight. We have another webinar scheduled at 8 o'clock with regard to advanced courses, where we surely will address a number of more questions with regard to restart the courses. Thank you very much, everyone, and stay safe.
Thank you as well.
Bye-bye.
Bye.
Bye-bye.